following program has been pre-recorded, so please hold your calls.
Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
Good evening and welcome to Conspiracies Against Wellness. I'm your host, Janelle Elgaway. If you have a question or comment for our guest this evening, please call in at 415-915-2291. Tomorrow night at 8/7 Central, Beth will share her family's personal experiences with chronic pancreatitis disease and what it's like living with major health issues. This week, we will continue the discussion on urinary drug testing. Tonight, we have guest Dr. Jeff Fudin. How are you this evening, Dr. Fudin?
I'm great. How are you?
I'm great, thank you. And thank you so much for coming on and welcome to Con Nation. If you wouldn't mind, would you please tell me a little bit about your background and what we'll be discussing this evening?
Sure. So I am a clinical pharmacist. I've got a doctorate degree in pharmacy. I graduated with a bachelor's degree in pharmacy. Before that, I spent more than 3 decades as a clinical pharmacist in a VA hospital, 2/3 of which were in an ambulatory care pain specialty clinic, and that was comprised of a multidisciplinary group of clinicians, physiatry, anesthesiology, neurology, pharmacy, nurse practitioners, behavioral health, psychology, psychiatry. So we had quite a large group of people. I also have academic affiliations at several colleges of pharmacy, and I do a lot of legal work as an expert witness. And in my spare time, I started a software company that basically we write software around opioid safety. And one of my software programs, actually called UrinTel, is an application to help patients and providers interpret urine drug screens.
Okay. What was the original purpose for urinary drug testing or screening?
Well, the original purpose actually had nothing to do with opioid therapy in terms of patients that were legitimately prescribed opioids for pain. Originally, urine drug screens were intended to monitor patients who had a substance use disorder, which is a more generic term to describe patients who might use misuse or abuse any medications, including amphetamines, quaaludes, barbiturates, whatever. And so the original intent was very different than it's morphed into today.
Mm-hmm. When did the focus become more on the opioid issue or people that are taking opioids?
Well, it's hard to pinpoint it exactly. I would say that probably in the mid-2000s, perhaps. I think that it took a very sharp turn, though, around 2012, when a petition was submitted to the FDA asking them to change various ways that opioids are prescribed. And I think that really caused a lot of havoc, made people stand up and pay attention to some of the issues and dangers with opioids. The standards of care started to change in 2012, and then it was in 2016 that the CDC came along and said, it came out with guidelines and basically said that urine drug screening should be part of your opioid treatment plan. But it was before 2016 that people started doing this on a more regular basis. The other thing that happened between 2012 and 2016, a lot of lab companies popped up all over the country, and a lot of them encouraged incentives for providers to order more lab tests. Some of those lab companies were sanctioned, some went out of business, some paid millions of dollars in fines. So there's all sorts of politics in the background that have been going on at least since 2012 and probably a bit before that.
You mentioned a minute ago how opioids were prescribed that made them pay attention. How were they being prescribed that caught their attention?
Well, I mean, opiates have always been used, but I'd say that in the mid-'90s, people started prescribing extended-release opioids on a more regular basis than they had. I mean, there was no extended-release opioids before. Gosh, I think it was the early '90s. The first one out was MS-Contin, and I mean, people still prescribed opioids, but they weren't routinely prescribed the way they are today for chronic non-cancer pain. And people started to feel more comfortable prescribing opioids for chronic non-cancer pain over the years. And there was more and more extended-release products that came out in the market. People felt more comfortable prescribing them. But the problem is that a lot of people that were prescribing them, I think, were under the impression that if you had real pain, that there was no issues in terms of addiction. And that wasn't true. I mean, we know that there are problems with opioids, as there are with all drugs. But there's ways to properly monitor them, to assess risks of patients, to make sure you stay in close contact with patients, and so on and so forth. So, I'm not saying that in the last 5 years that the way people prescribe them necessarily are different. Although I will say in the last 2 years, the daily equivalent morphine doses have come down drastically across the nation. That's for certain. But the problem, I think a lot of people see the problem, at least blame the problem on prescription opioids. And we see a lot of that in the news. And that clearly, it couldn't be further than the truth right now. I mean, certainly prescription opioids can be problematic, and people certainly abuse them. But the truth is that opioid prescriptions have come down significantly since 2014. And in the last 2 years, they've come way, way down. And also the daily prescribed doses have come down. Yet at the same time, the overall opioid-related deaths have increased. But they have increased not because of prescription opioids. They have increased partially because of heroin. But the other part is that there's illegal fentanyl derivatives, not fentanyl, but fentanyl derivatives being sold here from other countries. The most popular one of which is carfentanil, which is 1,000 times more potent than morphine. So you can imagine people that are selling heroin on the street, they're using small amounts of this carfentanil because you need so little of it, and they're basically lacing the heroin with it. So people that abuse heroin are not really, they don't really know how much carfentanil is in there, and a lot of them are dying. But a lot of the politicians and journalists are basically lumping all the data together and saying, look, opioid deaths have gone up. Or they're saying, some people are saying it's due to fentanyl, but it's not due to prescription fentanyl. It's due to this bootleg fentanyl that's coming in mostly from China. So, it's really a pretty hot mess. People are being misled in a big way. However, it's still important to monitor patients, whether they're legitimate patients or not. It's really part of the standard of care now.
Right. So if a patient comes in, say they're a pain patient, and they are taking opioids, and the doctor's going to be prescribed them, how should a doctor communicate to a patient about what a urinary drug test is and what they'll be looking for? Or how should they communicate, period?
Yeah, so that's a great question. I've heard all sorts of things. I've heard doctors say, well, I don't really want to ask my patient for a urine drug screen because, I've got a great relationship with them and they don't trust me. And I want to give you some background before I answer that question. Or I've heard oncologists or people in palliative care or hospice say, it's ridiculous. We're not going to monitor our patients for their urine for opioids. My God, they're dying. So here's the thing. I think just like if we're going to prescribe Coumadin or warfarin for a patient, we order INRs. We want to see what the clotting factors are. We want to see if the patient's at high risk of bleed. If we're prescribing antibiotics and the patient's not responding, we need to get cultures to make sure that we know what bacteria we're treating. If you're prescribing opioids, part of prescribing opioids is doing the proper monitoring. So if a patient comes in, let's say, and they haven't had chronic opioid therapy, the proper way to approach this is to discuss with the patient what the benefits are and what the risks are. A lot of times, the risks of non-opioid therapy are far greater than opioids, even in a patient that has a history, not maybe of opioid abuse, but maybe of dose creeping. So they take an extra tablet here or there, and to the clinician, they're misbehaving. All right, and that's kind of a different issue. But even in a patient who doesn't have the best compliance, even in those patients, opioids in some instances may be safer. So I'll give you an example. You have a patient that's got coronary artery disease, diabetes. They're on certain antihypertensives, some of which are used to protect against kidney dysfunction. Those things would preclude the use of NSAIDs because the NSAIDs could kill a patient like that, or if the patient has a high risk of bleed. So the discussion should go like this. Let's say you have a patient like that, and they have a previous history of, let's say, dose creeping, taking extra doses. You would say to the patient, look, I know you've got chronic pain. We need to treat it. You're having a problem functioning. You can't go to work. You can't take care of your kids, whatever the problem happens to be. And here are my choices. If I give you acetaminophen, it's probably not going to work for the kind of pain that you have, assuming that this is a very horrible, very horrible pain that can't be treated with very mild therapy. So patients try acetaminophen, that's not going to work. The patient can't take anti-inflammatories because they've got some of these other medical disorders, and the anti-inflammatories could kill them. So now you're left with the lesser of the evils, which may be opioids. All right. So this discussion has to be had with the patient. There's risk of addiction. There's risk of, there's tolerance that you may need a higher dose to treat the same disorder. There's all these other problems, potential risk of respiratory depression. So you need to go through all the side effects with them. And then you need to you need to speak to them about basically what the package is. All right, so look, I'm going to consider giving you opioids. If they don't work, we're going to take the opioids away, and we're going to taper them. So it needs to be kind of an escape route for both the patient and for their prescriber. And you need to discuss with the patient. So if you're going to go on opioids, we have to be consent. You have to sign a consent that I had this discussion with you. We'll adjust your dose as appropriate. And I say to the patients, look, you go to the internet, pick up the papers, there's a problem. And because we have a problem with opioids in this country, I have to be responsible when prescribing these, and part of that responsibility is doing an opioid agreement, just like you do a consent for surgery, and I have to monitor you. Now, there's ways of assessing risk in patients, and so you do these risk assessments, which are questionnaires, and you decide whether the risk is low, moderate, or high. And if it's low, then the consensus guidelines, there was consensus guidelines actually that were published in January of this year. The consensus guidelines are pretty clear. It says that urine drug monitoring should be performed at baseline for most patients. And if they have a low risk, it should be once a year. If they have a mild risk, it should be 2 or more times a year. And if it's a high risk, then it should be 3 or more times a year. And so all this stuff needs to be discussed with the patient. And the other thing that needs to be discussed with the patient is when the results come back, right? Because there's a lot of potential for false negatives and false positives. And so the patient really needs to understand what those results mean. And so does the clinician.
Mm-hmm. So if you do have a false positive, how should, the clinician or doctor handle that with their patient?
So, great question. So the drug screens that are most often done, or drug monitoring that's most often done, are screens. And those screens are immunoassay screens. That's by definition, they're immunoassay. Mm-hmm. And so for me to explain this to the listeners, an immunoassay is an enzyme test. And so we kind of think of it as putting two puzzle pieces together. One puzzle piece is the drug, let's say morphine, and the other puzzle piece is the enzyme in the test that binds the morphine. If the two puzzle pieces fit together, then it's a positive test. If they don't fit together, it's a negative test. So here's an interesting thing. So the urine screens basically test for 5 drugs usually. And one of those 5 drugs is listed as opiates. The truth is, it's really not a test for opiates. It is a test for morphine. And so what will happen is that for morphine, even at low doses, it's always going to test positive. It will always test positive for morphine if you take codeine, because the body converts codeine to morphine. It will always test positive for morphine if you take opium, because opium is concentrated morphine. It will always test positive for morphine if you use heroin, because heroin is diacetylmorphine. It's 2 morphine molecules that are attached with a kind of like vinegar in the middle, or acetic acid in the middle. So here's the rub here. So there are a number of opioids that share the same chemical nucleus as morphine does. All right? And so these would be very familiar drugs to a lot of our listeners. Those are drugs like oxycodone, hydrocodone, hydromorphone, oxycodone, brand names Dilaudid, Percocet, Lortab, Vicodin. Those all share a similar chemical nucleus, but they are not identical. Okay? And so they will not test positive at low doses for morphine. Now, go back to the puzzle piece analogy. If you have 2 puzzle pieces that look like they will fit, but they don't fit, sometimes you can force them together. All right? And so I try and describe it that way is because if you saturate the blood, or the urine rather, with high doses of these drugs like oxycodone or hydrocodone, it will test positive. So if a patient is on a minuscule dose of hydrocodone and they test positive for opiates, my concern is that they're taking something other than prescribed. Right? Now, and so some doctors may see a positive result and say, oh, that's great, patient's getting Lortabs, the urine is positive. Well, that actually is a problem. Now, there are other opiates that should never test positive on an opiate screen because the chemical nucleus is completely different. An example of that is Demerol or meperidine. That shares the same chemical nucleus as fentanyl, which is available in many dosage forms. Another drug that doesn't have the same chemical nucleus is methadone. That should never test positive for opiates. You have to do a separate test for methadone. Another drug called Nucynta or tapentadol, that will not test positive. Tramadol or Ultram will not test positive because they all have different chemical nuclei. So, I mean, and now we're just talking about opiates. There's all these other drugs that they're testing for also. They have a potential for false negatives and positives. So, if a result comes back that's unexpected, really the clinician should sit down with the patient, as I do, and explain to them what it means. Now, sometimes it's extremely clear. It's like, no, I know you were taking this drug. There's no chance of it being false. Now, that's kind of rare with an immunoassay test, but it's possible. So, for example, if somebody has a positive for cocaine and they swear up and down that they didn't take cocaine, not true. Because there is no false positive even by immunoassay for cocaine, because we're not testing for cocaine, we're testing for a cocaine metabolite. Like I've had patients come in and say, oh, well, I went to the dentist, I had lidocaine, and my friend told me I can test positive. Well, my first question is, why are you even having this discussion with your friend? And my next comment is there's no way that lidocaine could possibly test positive for cocaine metabolite. So, I mean, but you have to be, I think, honest with the patient. Sometimes, like, for example, if I had a patient on low-dose hydrocodone and they came back positive for morphine, that would concern me. So I would send it out for a confirmation test to make sure it is what it is. So oftentimes I get patients to test positive for cannabinoids or marijuana. And there are a lot of over-the-counter medications that can cause a positive cannabinoid test. So it's really in the patient's best interest for me to order definitive testing, irrespective of what the cost is, because they don't want something in their chart that says that they took a drug that they didn't take.
Right. Let me ask you something, because I'm a chronic, I'm a CPP patient of 24 years, and for the last 16 years, I've had to get drug testing pretty much every month because I've been on, certain medications. But back in October, I did test positive for cocaine, and you're saying that it's hard to do that, right, because of the metabolites. Why would I? They ended up letting me do a hair sample or a hair test, so they were able to see that it wasn't me. Did they possibly mix up my urine sample, or?
Okay, so I'm guessing that the hair sample came back negative.
Yeah. Okay.
So here's what can happen. I've seen this a lot in drug court. It is rare that they would mix up the sample, but it's possible, but rare. More likely than not, if you're in an office where they're doing drug tests every month, to me, it sounds like they're over-testing. Now, I don't know, because I don't know you. I don't know your history. Right. But if they're doing testing once a month for every patient that comes in, that's an awful lot of tests. And depending on what kind of tests they're doing, like if they're doing immunoassay tests, then in the lab there's these columns that the drugs are exposed to. And if the columns are not properly washed, then it could get contaminated from the previous test. Okay. And would usually be a very, very, very low level, which is in part indicative that it was a contaminated column as opposed to somebody actually using cocaine. Okay. I've seen it with gabapentin in drug court, and I've seen it with buprenorphine as well.
Really? Okay. Because I was just so shocked that this happened, and I waited until I got my hair sample back to make sure, to say anything publicly. But when I did, so many people responded as well and said, the same thing happened to me, but I didn't fight it, and now I've lost all my care. And that's why I did fight it, because I didn't do this, but, I couldn't lose my care. There's no way I could do that. And it just makes you kind of, it's hard for patients at that point. Is this, okay, so false positives, how often how often do they come up on tests? And how do I want to ask this? With a false positive, how often is it that it's actually an actual false positive and it's not real? Is there any data on that at all?
Not really, because it's all over the map. It depends on the kits that they're using. It depends on whether it's a cup, like some offices have these immunoassay cups. Some are more accurate than others, so it's really hard to say. But here's what's easy to say. So, for example, the software program that I wrote, I feel is fair to the providers and to the patients. So if the result comes back, what it will say. Let me give you an example. So the doctor basically selects the drugs that the patient is on in a drop-down menu, and then the next screen, you put down, you basically click whether or not the results came back positive or negative. So let's say that the patient came back positive for, let's say it came back positive for amphetamines, right? And they're not being prescribed amphetamines. What it would say is positive amphetamines are not expected. The following is a list of drugs that can cause a false positive. consider definitive testing. Use your clinical judgment and to consider definitive testing. So, I mean, I would go to the patient and say to the patient, you know what, you're positive for amphetamine, but you're being prescribed XYZ. Maybe the patient's got Parkinson's disease, and they're getting they're getting dopamine. Maybe they're on propranolol for heart disease, which has a similar chemical nucleus to amphetamine. So, I mean, there are reasons it can be test positive, but then I'm saying to the patient, look, this test is unexpected. It's clear to me why it was positive. I'm not going to send it out for definitive testing. But to somebody else, it may not be clear. And because it may not be clear, it may be important to send it out for definitive testing so that you can put that in the chart so that people don't have to go through what you went through. I mean, if a patient is on levodopa, for example, because they have Parkinson's disease, there's a very good chance they could test positive for amphetamine, and that's an unexpected positive. So the way that it should be worded is that this is an unexpected positive. I can or I cannot justify why this would happen. And if the answer is I cannot justify it, then you almost have to do definitive testing because you want to clear the patient. Or if the patient's not being honest, then you basically want to be able to identify if the patient has a problem, and the patient may need help.
Is this
it goes ways. I mean, the clinician has a responsibility to help the patient one way or the other. I mean, if I've got a patient that's a problem, I don't discharge the patient. I offer them help. More often than not, I'll tell them that I can treat their pain with other than opioids. There's a lot of ways to do that. And sometimes, if there's not any really good choices, I might treat their pain with buprenorphine because it's a safer option.
Why do so many doctors, though, just, if the test does come up false or positive, for something, why do they automatically just shut down on the patient instead of wanting to treat them? Because you think that they would, being a doctor, right? Or is it just that they're so busy and that's not their forte?
Well, I think there's a lot of issues. I think that, especially now, the new CDC guidelines basically state that doctors should be doing urine drug screens, right? And so, I mean, imagine if you have a doctor that's not comfortable treating depression or schizophrenia, okay? And new guidelines came out and said, well, you primary care doctors from now on have to treat this. I mean, they either wouldn't see the patients, or they'd feel very uncomfortable, or they just wouldn't do a good job at it, right? Mm-hmm. So it's the same here. And this is not unique to physicians. It's pretty common with all healthcare providers, with physicians, with NPs, with PAs, with pharmacists, with nurses. It's pretty much the same. The education in professional schools for pain management is very, very poor. The amount of hours that is dedicated to teaching pain management is ridiculous. And when you consider that the prevalence of chronic pain is higher than diabetes, heart disease, and cancer put together, and that those three things together in any of these professional schools probably has more than a month dedicated to it. I mean, heart disease alone has 3 or 4 weeks dedicated to it. It doesn't make any sense. So the first answer to your question is that, unfortunately, most clinicians are over their head, at least with complex pain patients. They just do not have the training, and usually the first to admit it. And that's not the case with everybody, but I think for the far majority of them, they don't feel comfortable with treating pain. Now, on top of that, they feel intimidated because of the opioid epidemic, and a lot of states are putting caps on the amount of opioids they can prescribe. Some states are actually running reports to see which doctors are outliers in terms of morphine daily equivalents, and they're doing random chart reviews to these doctors. I mean, so doctors are, they're intimidated. And then you have the other issue is that they really don't know how to interpret these urine drug screens. And if all of that wasn't enough, you've got managed care dictating how many minutes you can spend with the patient. So you got 15 minutes to see the patient. The amount of money you get paid to see a patient keeps going down, and in that very short period of time, you've got to ask the patient about their hypertension and their diabetes and their depression and their fibromyalgia and their chronic headache disorder and their pain and God knows what else. Then you got to do all the lab tests, and then you're supposed to spend time explaining the lab tests. And with patients that are on reasonable doses of opioids, the consensus is these days that they should probably go home with in-home naloxone. And the caregiver should be taught how to use it in case there's a problem and the patient overdoses. So all of that stuff takes a tremendous amount of time, and really most clinicians don't have that amount of time.
Well, isn't that why, though, we have specialists? Like, I mean, because I get primary cares and stuff like that, but wouldn't specialists, you know, be able to talk about each individual, and that's what the doctor would go to? Because it seems like that's what every patient has to do anymore, is go to a specialist.
Well, I'm glad you asked that question, because there are actually some states, a.k.a. Washington State, I think was the first state that did this, that require that if you're on a certain milligram equivalent, if there is such a thing, that's another whole issue, that you need to go to a pain specialist. The truth is that most pain specialists don't want to prescribe medications. Most of them do procedures. Not all of them. There's a lot of them that will prescribe medications, but I would say the majority of them probably don't. And the other thing is that physicians that specialize in pain, it really depends on where they're trained. Most physicians that specialize in pain, they do a lot of acute pain management, like in the hospital setting, and they do a lot of procedures, but they are not experts in pharmacotherapy. They just aren't. I feel like, I mean, no physician is an expert in all medication management. I mean, nobody can be expert in everything. That's for sure. I mean, cardiologists are great at knowing their cardiology drugs, and endocrinologists are great at knowing their endocrinology drugs, but nobody can know everything. And so a lot of times, especially when I'm in court, you know, I try and explain to these attorneys that, first of all, the physicians are held to a certain standard of care. And as long as they meet that standard of care, you know, everything should be okay. And if they feel that they're out of their league with a particular problem, then, of course, they'll refer the patient to a specialist. Primary care doctors or internists have a very tough job because they really have to be somewhat of an expert in a lot of areas, particularly if they're in a rural community. But the truth is, physicians really spend the majority of their time doing diagnostics when they're in school. And pharmacists spend the majority of their time doing therapeutics. They're experts in therapeutics. So sometimes I'll order a pharmacogenetics test. Maybe a patient's on a very high dose of oxycodone. Start asking them questions. They were on various different antidepressants or various other different drugs. And as they're telling me the side effects, in my mind, as I'm sort of going bing, 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 these all share a common enzyme system. I bet you that genetically this patient's deficient in that enzyme or hyperexpressive of that enzyme. Let's do a pharmacogenetics test. And sure enough, the test comes back. I'm like, well, you know what? This is the reason why you didn't tolerate these drugs. We need to start thinking about other ways to treat your pain. This is an area that most physicians do not have expertise in. And I feel like we have this big problem with opioids in this country. And one of the issues is that managed care organizations, third-party insurance payers, don't want to pay for anything unless it's cheap. So they would prefer that everybody is on inexpensive generic hydrocodone or generic whatever. For example, they don't want to pay for pregabalin or Lyrica. They'd rather pay for gabapentin. Well, gabapentin is harder to titrate. You have to titrate over time, with the exception of two unusual branded drugs. But again, they're branded drugs. So the insurance companies don't want to pay for the more expensive drugs. They want to limit physical therapy. They want to limit alternative therapies like acupuncture and things like that. And they're not taking a hit at all for some of the overprescribing of opioids. I mean, I think that there's a lot of patients that need opioids. I think that they have been overprescribed in some cases. In some cases, they've been underprescribed. But insurance companies have not taken a hit. And, I mean, I've been working as a clinician for years in a clinic seeing pain patients, adjusting their medications, ordering the prescriptions, doing the blood work, doing the urine screens. And I'm a PharmD. I'm not an MD. And so every single clinician that you can think of, social worker, psychologist, podiatrist, optometrist, nurse practitioner, PA, physician, you name it, they can bill to see a patient, but pharmacists cannot. And in the VA system and in the DOD, they consider pharmacists to be providers. And the pharmacy organizations have been lobbying Congress for years to have pharmacists be recognized as providers. Imagine if you had a pharmacist in some of these practices that were helping. Now, you asked me a question. You said, well, you know, if they're sent to a specialist, why wouldn't a specialist do this? So, well, the simple truth is that not all pain specialists are experts in pharmacotherapy. They're experts in diagnosing. They're experts in doing injections and blocks. And many of them are expert in pharmacotherapy. That's true. But many of them are not. And even if they are, they may choose not to write medications because it's too much of a hassle. And if they feel like they have to write medications because primary care providers won't, more often than not, they hire PAs or nurse practitioners to do all of the medication management.
Right.
So well, it's just
right. And you were mentioning earlier, you know, the doctors have to do this. They have to know all of these different things and stuff like that. If they did pull in pharmacists, wouldn't that, you know, take the load off of them a little bit to at least do the generalized things that they need to be?
Oh, absolutely. I mean, some of them are starting to do it, but they take a loss because they can't really bill for the pharmacist's visit. But some of them, you know, have busy enough practices, they're willing to take the loss because of the liability and because of the expertise that they're getting. They're willing to pay a pharmacist to do that because the pharmacist can do other things there. The pharmacist can mix the medications that they're injecting. You know, they can do a lot. They can interpret the lab tests. They can work with the chemist there if they're doing labs in-house. So, I mean, the answer is yes. But, again, Congress has not recognized pharmacists as providers. 3 states have overridden that. So New Mexico, California, and Washington, pharmacists are considered providers. So you may see more pharmacists in those practices, but it's rare in other states unless you work for the federal government. Like the Indian Health Service, and as I said, the VA and the DOD have been using pharmacists as clinicians for years. And I mean, it's not just pain management. I mean, so it's very interesting. I have a daughter that is an assistant professor at the University of Utah, and she's a PharmD. And so part of her time is spent in a clinic. And so the way that they work it out, and some other people have worked it out, is third-party payers have arrangements with doctors that, you know, the better they do in terms of outcomes, whether, you know, for diabetes management, hypertension, things like that, then they get reimbursed, they get a bonus. And so what some clinics are doing is they're having their PharmDs do the medication management. The outcomes are better, the reimbursement is better, and then they use it to offset the salary of the PharmD. It's crazy, but that's what's happening.
So we have a question from YouTube. Why do they need to send my pee to Dallas from New Orleans for a standard 8-panel test on the side of the container?
Can you repeat that? I didn't hear that question.
Sorry. They asked, why do they need to send my pee to Dallas from New Orleans for a standard 8-panel test on the side of the container?
So they don't need to do that, but if a company... So some of these companies, it's less expensive for them if they have a huge lab someplace, maybe in New Orleans or wherever it happens to be. If they have a huge lab, it's less expensive for them to have a courier service collect all the samples and send it to one location where they're running thousands and thousands of tests than it is to have lab centers spread out like all over the country. I mean, different labs have different ways that they do it. So some labs actually, some larger labs do have collection centers all over the country in several places within cities. So That's one model. Another model is to have a major, huge lab in one location and having all the samples sent there. And so it may be less expensive for them to do it that way. And maybe the clinician gets a better price. Or again, maybe a third-party insurance payer has a preferred provider contract with that particular lab. The lab gives them a break because in exchange they basically say, like the insurance, like I don't know, Blue Cross Blue Shield, whoever it happens to be, may say, this is our preferred lab. You need to use this lab. Everybody's going to use this lab. And so the lab gives them a break, but that lab happens to be New Orleans, so that's where everything goes. That's the reason why. It's all about cost.
Okay. Does it matter if a lab is certified or doesn't it?
Oh, yeah. The lab needs to be, there's very strict criteria about how labs need to be certified. There needs to be quality assurance and all that sort of stuff, yes.
How many labs across the United States are certified?
Oh, I have no idea what the number is, but I would say most are. And you can easily check that. I mean, patients actually, if they never heard of the lab, and they want to know whether they're a reputable lab and if they're properly certified, then they can easily go to the internet and check that out.
Okay, great. We're going to take a call if that's okay from you.
Sure.
Caller from area code 406. What's your name and where are you from?
My name's Lindsay, and I'm from Montana.
Hi, Lindsay from Montana. What's your question for Dr. Fudin?
Well, I'm kind of have, I guess, my question, and it's kind of an experience. See if maybe Dr. Fudin can interpret it, I guess. At the pain clinic that I was going to here in Montana was one of my UAs that I had taken. I guess little background was that I had spoke to both the PA and then also my rehab specialist when I had taken, I guess, a while before that. I had asked about if it was okay as long as I didn't take my medication prior to that, if I had ever went out to dinner or with friends to have a couple of drinks, no more than 3, if it was okay with both my doctor and also my PA. And they had said to me, well, if we didn't allow our patients to have a drink or 2, we probably wouldn't have any, and they just laughed. And then it was probably maybe a week or 2 after that, I had a UA and never heard anything about it. It was probably maybe a month or 2 after that, I had gotten a telephone call. They had done some different things with their administration, and then when I had finally got a call about it, they had spoke to me about my UA and had said, oh, you had drank way, way too much alcohol. And then they had told me that the DEA had been cracking down on the amount of alcohol that you can drink with your medications. I was wondering if you possibly knew anything, if any of that is happening. I probably had about 2 drinks with dinner, I guess. And I just was curious about that, if you were possibly aware if they're doing anything with that. And, I know the dangers, of course, of drinking alcohol in your medications, but...
Okay, so there's a few issues here. Issue number 1 is that a large number of opioid-related deaths, in fact, most opioid-related deaths are not from opioids alone. They involve opioids plus alcohol and or benzodiazepines like Xanax, Valium, diazepam, things like that. So I just want to start out by clarifying that. And you said that you realize that there's dangers of taking alcohol and opioids. So that's the very first part of my answer. Very important for the listeners to recognize that. The DEA is not concerned, nor do they have any business in treating patients clinically. And they will be the first ones to tell you that. That they don't monitor patients' urines, and if somebody told you that, it is untrue. Now, the FDA has come out with warnings, about alcohol and opioids, and every manufacturer has it on their label, and I'm sure it says in your prescription bottle, do not drink alcohol while taking this medication. Now, if your doctor did a urine test and it came back positive for alcohol, it's not alcohol that they're testing for, it's ethyl glucuronide. And ethyl glucuronide is a function of how much alcohol was used, not necessarily yesterday or the day before, but sometime within the last 3 days. Now, if that comes back over 10,000, then it would be clear to me, I don't know what your level was, but it would be clear to me that there was many more than 3 drinks over the course of 3 days. If, on the other hand, it came back 150 nanograms per mil, then that's more indicative of a drink or two the evening before. So the person that looked at this would have to know how to interpret it, for one thing, but it is not appropriate to wait 2 months and then reprimand a patient for drinking alcohol 2 months ago. When that level comes back, the clinician has a responsibility to call the patient and address it at that time, not 2 months later.
Thank you so much, Lindsay, for calling in. We have a question from YouTube Live. Stacy Fields wants to know, why are UAs $1,700? Or why are they so expensive?
So a urine analysis, I don't know what's in that urine analysis, but the standard 5 drugs they're tested for should be way less than $100. And if somebody's charging $1,700, then I would be calling the Attorney General's office.
Well, I know that's what I've heard. A lot of people that their insurance doesn't cover it, and that's what they pay for. What about hair tests? How much are those expensive?
They're more expensive, and hair tests are not considered the standard of care. So, hair tests are more expensive, and there's all different prices for hair tests, so I really wouldn't be able to comment so much on that, because they're really all over the board. But some insurance companies, like I said earlier, they have preferred providers. And so what some of these companies do, they'll charge the insurance company, they may bill them $1,700, but the insurance company will pay them $40. And then they'll accept it because they've got a deal with the insurance company. And then if somebody's paying cash, they'll charge them maybe $200. But $1,700 is out of control. Now, I don't know what they ordered and whether what they ordered was appropriate or not. Some people order like all these crazy drugs that there's really no reason to order them. And some of the labs have bundled them together, kind of like when you buy a car, I want a sunroof. Oh, well, if you want a sunroof, you have to have leather seats, and you have to have, this special thing in the back, and you have to, so that's what some lab companies have done. A lot of them have been reprimanded by the federal government for doing that. So if somebody's charging that kind of money, I would contact, first of all, I'd want to know what tests they ordered. Because if they order all these crazy tests, then the doctor needs to be held accountable for ordering those tests. Like, why would you be ordering all these crazy tests? What is the possible reason? It's not the standard of care.
What is crazy? What do you mean? Like, are you talking about, obviously there's the 5 that most prescribed for, but what's after that that's really out of there?
Well, sometimes they order all sorts of drugs. So not only do they order opioids, so it's standard to order opiates, amphetamines, benzodiazepines, barbiturates, and cannabinoids. Mm-hmm. Those are the 5 standards. Now, sometimes they will also order ethyl glucuronide, which is a function of alcohol, and I agree with that. Maybe not all the time, but occasionally. And sometimes they'll order methadone because that's a pretty popular drug on the street. Sometimes they'll order buprenorphine because that's sold illegally on the street as well. But then you'll see them ordering other stuff, gabapentin, pregabalin, amitriptyline, maybe testosterone, which is sometimes abused. Why would you order testosterone like in a 70-year-old woman? That's kind of stupid, right? So they just have this huge panel that includes all this crazy stuff. Then they may add something like kratom. They may add spice or synthetic cannabinoids. They may order cathinones, which are bath salts. They may order fentanyl. So all these drugs, in a patient that has a low risk of substance abuse, I mean, a patient at a very, very high risk, I could see ordering some of these drugs, but there's no reason to order 25 drugs in a person that is not expected to be a problem.
Right. Are there more accurate tests than the urinary tests and the hair samples?
Is urine more accurate than hair samples? Is that what you're asking me?
Well, no. Are there more accurate tests than those? Because, actually, I guess then first from the urine test. But are there anything else? Is there anything else out there, or does it get more expensive, or how do they do this?
Yes. Yes, there are. So there's a few different kinds of tests. So, and this is true for urine and blood. So the urine tests are typically done in the doctor's office, and also their send-outs that have a quick turnaround are the immunoassays, which we spoke about. Then there's something called an ELISA test, which is a more specific immunoassay, but it's still an immunoassay and subject to false negatives and false positives. That's more expensive, but when they're bundled with insurance companies, it's not really too much more money. Then there's the sort of the Cadillac of these tests, and they're called either gas or liquid chromatography. That's considered definitive testing. So that's 99.9% accurate. So if you do, and that's why I said earlier on, if you have an unexpected result and you want to send it out for definitive testing, that's when they do chromatography testing. And that's extremely, extremely accurate. The only time you would have a false test is if either the sample got mixed up or the columns were contaminated from a prior test where somebody was running, thousands of tests back to back. So that's possible, but that's also very unlikely. So the chromatography tests are extremely, extremely accurate. Sometimes, though, like the clinicians need to know how to interpret that also. I'll give you an example. If a patient's being prescribed morphine and you do a definitive test by chromatography, you're going to probably, especially if it's something called tandem liquid chromatography, you're going to probably get a positive test for morphine and hydromorphone, which is diluted. And that's because a very small portion of morphine gets metabolized in the body to hydromorphone. But it's so accurate that very, very small levels will show up. So that's an issue. If, for example, you did an immunoassay test for benzodiazepines, which include Valium and those sorts of drugs, and you were on Xanax, also known as alprazolam, or you were on clonazepam, those are expected at lower doses to come back negative because the immunoassay doesn't recognize them. So that's a case where I'd want to send it out for definitive testing to make sure you were taking the drug that was prescribed. So there are different kinds of tests, and it's important to know what kind of test it is and how to interpret those tests.
Okay. We have another caller from area code 209. What's your name and where are you from?
Hi, Janelle.
Yes.
This is Ariane.
Hi,
out in California.
How are you?
I'm calling. I've been sick, so you're going to have to forgive me if I'm a little out of it. But I'm calling kind of to touch on why we're not talking about this urine drug testing for pain patients sort of being a profiling technique. Because, to my knowledge, it's the only disease process, and it's really not a disease in and of itself, although some like to classify it as such. But usually, patients have other diseases that cause pain complex. And it's the only time that we're basically mandating that patients be urine drug tested for street drugs, etc., even though people with heart disease, diabetes, hypertension, other diseases, if they're taking street drugs, it can harm them as well. So if we're just going on patient care and safety, one would kind of say that drug testing should be done on every patient to make sure that they're being treated appropriately, they're not abusing street drugs that could interfere in their care or interact with medicines that they're on.
Okay, so that's a good question, very appropriate. So here's how, so I'm a clinician, and I prescribe these drugs. So I can give you an answer from my perspective. If a patient, use the example of a patient that, say, that had heart disease. If I was prescribing beta blockers or calcium channel blockers or whatever to a patient for their heart, I would be monitoring their blood pressure. I would be monitoring their anxiety, their environment. I would be asking questions about those sorts of things. If the patient had, let's say, an atrial rhythm problem, and I had to have them on Coumadin for that, a blood thinner, I would be monitoring their INR. I want to make sure that if I'm prescribing a drug to them, that their blood work is within safe parameters. And I will counsel them about what kinds of things that they should and should not eat, because it could affect how thin their blood gets because there's interactions with the drugs. If I am prescribing a sedative hypnotic, all right, then I want to monitor the kinds of things that would create dangers under those circumstances, because I, as a clinician, have a liability. So if I'm giving opioids to a patient and they are taking a benzodiazepine like Xanax on the street and smoking pot, I have a liability. And not only do I have a liability 10 years ago, but now I have a liability because it's become the standard of care. And so if I go to court and something happens to my patient and they die, and then the family sues me and says, why didn't you monitor the patient because of the standard of care, I wouldn't have a leg to stand on. I'm not saying whether it's right or wrong. I'm just answering the question. So as a clinician, if I'm ordering a drug, I need to do the tests to ensure that I'm putting out that drug into a safe environment. If I'm an endocrinologist, I want to make sure that the patient isn't taking some kind of drug that's causing a problem. So, for example, if I was a cardiologist, I would be concerned if a patient came in with an 18-inch neck that was very bulky on top, because I would be concerned that they were taking testosterone and lifting weights, which can cause heart problems. So the various specialties that you mentioned do have an obligation to monitor certain drug levels or blood work for certain other things.
So we're not talking about only monitoring the levels of opioids that are prescribed. We're talking about monitoring people for street drugs routinely because they're given a certain drug, i.e. opioids, which to me, unless you've been either officially diagnosed with an addiction issue or convicted of a drug crime, is profiling.
Well, that's, you're entitled to that opinion. I'm just answering your question. You asked me, why do people do that? I'm telling you.
I worked in nursing, and hypertensive patients aren't routinely monitored with blood work. My husband isn't. He's given prescriptions every month. He doesn't even go in for routine checks, maybe once or twice a year.
Well, I'm not talking about hypertension. I was talking about heart disease, right? So that's what I'm talking about. For hypertension, I would tell a patient, don't take any over-the-counter medications. I wouldn't want a patient with hypertension to be taking Sudafed. That could be dangerous, right? So I would counsel the patients. Certainly, you may think that it's profiling, and I'm not going to agree or disagree with you. I'm just answering your question. You asked me, why do they do it? They do it because they have a liability. If they're prescribing opioids.
Standard of care now based on a CDC mandate, and the AMA went along with it. And it wasn't because doctors got together and said this was going to be the best way of treating patients.
Well, the CDC guidelines are not a mandate. They've become, people think they're a mandate.
No, it's a standard of care. It's a standard of care which becomes, I believe, tort law as far as the standard of care in how we treat people with pain, correct?
Well, I'm telling you, you can read the guidelines. They are not.
No, I'm not talking about the guidelines. I'm talking about now the standard of care, which basically is medical law.
Yeah, so the standard of care now is urine screening for prescribing opioids.
Right. So now we are into a mandated situation because the standard of care is law. Therefore, drug testing is mandated.
It's not mandated. You don't have to. You don't have to do urine drug screens. You have a higher liability if you don't.
Right.
Doing INRs are not mandated in cardiologists or primary care doctors that prescribe Coumadin. But if you didn't do that, you'd be pretty stupid, right? Because if there was a problem, first of all, we want the most important thing is that patients are safe. So there are certain things that we do that are considered standard of care. Now, there are some clinicians that may decide to not follow the standard of care in certain circumstances, and that's up to them. I'm just saying that, you know, if something goes to court, there's a very high liability.
Well, especially given the false narrative that you take an opioid and you're going to become addicted.
Right. Well, I mean, that's debatable. I mean, some people have a higher risk of addiction than others. They should be monitored.
1%
and they should be
given prescribed opioids, from what I'm understanding, 1%, with no other history of substance use disorder. Correct?
I didn't catch what you said. Are you asking me, is it 1% with patients that are prescribed opioids? Is that what you're asking me?
With no other history of substance use disorder, have a predisposition to become addicted to opioids?
Well, there's not great data on that. The most recent data that I saw is that it's higher than that. I've seen as low as 2% and as high as 20%. The problem is that back in the 90s, when people started prescribing opioids, when clinicians were running around and experts were running around saying there's no risk of addiction in patients with chronic pain, was really not true, because it was based on inpatients in an acute patient setting, not in patients that were out and about on their own outside of a controlled environment that had chronic non-cancer pain. So we don't really have great data on that. It certainly is not 100%, and it's probably less than 15%, but I don't know what that percent is. I know that for alcohol, it's 12%, right? And people can buy alcohol whenever they want, and not everybody's an alcoholic, right? So we know there's 12% risk.
But isn't that part of the issue, too, is that, you know, with other medications that have risk, including gabapentin, which can be abused and cause physical dependence, we give patients informed consent about what the medication can do, and then it's a personal responsibility for that patient to understand the risks and benefits of what they're taking and assume responsibility if they start to abuse it. Instead, we have doctors playing parent alongside the government and basically trying to head off addiction before it happens. And meanwhile, patients are being marginalized right out of healthcare. And I refuse to even go in for routine appointments now because of how I'm treated. It's demeaning.
I don't think that doctors want to do this. I feel like they're being... Many of them are actually being intimidated into doing this.
Then why don't doctors stand up as a unified force? Because chronic pain patients have been being told we should be fighting for doctors, and I'm going to tell you, I can barely fight for myself day to day.
Yeah, well, believe me, I hear you. I've been advocating for patients for a long time. Unfortunately, you kind of got two camps of people who really should get together. You've got a lot of people in the addiction community, psychiatrists, not all of them, but a lot of them, or at least a group of them, that are lobbying that opioids are horrible things. That if you don't have cancer, you shouldn't be on them. You shouldn't be higher than a certain dose. The extent of these opioids should come off the market. I mean, it's unbelievable. And then you got people who have expertise in pain management, not in addiction medicine per se, who have been treating patients with opioids for years. They're saying, wait a minute, You know, the whole world is not going to become addicted to opioids if they're on opioids. And in fact, you know, we've had patients on opioids for years, and they've done fine, and they're functional. So the two communities have to come together. I mean, you're talking about certain providers, medical providers, that I get what you're saying. You know, that it's an invasion of privacy, and they're doing all these things, and that, you know, why don't they stand up? That I'm telling you, I'm on the side of the fence where I'm getting 10 emails a week from attorneys all over the country that are defending doctors, many of which have done nothing wrong. And so they are intimidated. They've got families too.
Part of that is the hype. Part of that is because it's being fueled by the media, and the doctors that need to be standing up fighting against the false narrative that's being basically spoon-fed to the public isn't happening. We have a voice here or there crying in the wilderness. The media refuses to listen to pain patients. They refuse to tell the story that's on this other side, the acceptable collateral damage of this failed drug war that they're fighting. And if doctors don't come out and tell the media, look, what you're saying is wrong, okay, what you're telling the public is not accurate, that narrative isn't going to change.
Well, I mean, a lot of people have come out and said that, and there are certain professional organizations that have come out and said that. The American Academy of Pain Medicine, the American Academy of there's a number of organizations, the Academy of Integrative Pain Management, the American Academy of Pain Medicine, American Society of Pain Medicine. There are a lot of societies that have come out and said this. There's a pharmacy organizations have looked at this. I mean, a lot of professional organizations are saying, in large part, what you're saying. But, you know, there's this pushback, you know, between the media and professionals, and the media, you know, they would rather print an article that says OxyContin are heroin pills. I mean, how many times have you seen that in the news?
No, I'm aware of the hype, and that's part of the problem because, you know, watching someone OD in the back of a car is more sensationalized than having a chronic pain patient in their kitchen doing their dishes. I get it. The thing is that we're the fallout of that. And the people who are barely managing in life anymore, and some who are committing suicide because they're in so much pain because they're denied needed medicine. Denied. Not because they did anything wrong, but because their doctors no longer want to have them as a liability, a potential liability. This is wrong. People are dying. People are going to be dying of cancer because of the stress that's induced by uncontrolled pain, from sudden heart attacks, strokes, from hypertensive issues due to pain. This is a disaster in the making for doctors and for people who are quote-unquote patients.
Well, I agree with you. In fact, I'm working with a group of people that we're trying to track how suicides have increased as a result of this, all this media hype, you know, and doctors being careful prescribing opioids. So I don't disagree with you.
I really hope we can turn this around before we have to count more suicides.
Thank you.
Anyway, I appreciate the time.
Yes, thank you.
Okay.
You know, something I wanted to ask you that she brought up too, kind of, is, you know, they're making these guidelines, and, you know, doctors are starting to follow all this stuff. Shouldn't they, because I know they want to have alternatives or other medications or whatever that would fully, you know, help a patient that has, and we're not talking about acute issues, acute health issues. We're talking about, you know, major intractable pain or palliative care pain. And we're not talking about cancer either. It's included in this. But shouldn't they have made sure that they have these alternatives before they started following these guidelines?
You mean alternatives other than opioids? Is that what you're asking me?
Yes.
So the standard of care is that opioids are the last option if you're going to use medications at all. I mean, the first option is no medications. The first options, you know, are exercise, physical therapy, heat. everything other than drugs, because, I mean, it doesn't matter what the drug is. I mean, you put something in your body, there's a potential problem. So if you move on to medications, then the medication should match the type of pain. So, for example, opioids are not great for tooth extractions. They're horrible, actually. Anti-inflammatories are better, especially the ones that don't cause as much bleeding. So, yeah, I mean, you should use drugs that are consistent with the diagnosis. Burning, shooting pain, that's oftentimes better treated with certain antidepressants that affect norepinephrine. And certain anticonvulsants, things like gabapentin. They are good in treating burning, shooting pain. If these things do not work, and or they are not tolerated or medically contraindicated, then you move on to opioids. Now, the truth is that opioids are not great for neuropathic pain either. There's a handful of opioids that are. And methadone is one of them. Most clinicians don't want to prescribe methadone, and rightfully so, because it's a very dangerous drug unless you have a lot of experience with it. But if you're experienced with it, it's a great drug to treat burning, shooting pain. Tapentadol is one. Tramadol sometimes. So yes, I mean opioids are fine, but they should never be used as a first-line drug.
Well, of course, and I'm not talking about acute. I'm talking about the major diseases like CRPS, RSD, chronic pancreatitis, arachnoiditis, EDS, stuff like that. And I apologize if I didn't mention it, but those things. And most people that have been on all this stuff for years and years and years that have tried other things, they've tried, the shots, they've tried other medications, they've tried acupuncture and everything else. And it's like the one thing that allows them to be able to get up and live daily. And that's what I was talking about. And that's the community I know myself. But before the CDC guidelines changed that for them, because instead of doctors using it for acute issues, I think across the board, they've just cut out everybody. And there's 26 million intractable pain patients out there, and 5 to 6 million right now have lost care already. In my mind, the CDC guidelines were a disaster. It was a disaster the way they were written. It wasn't even legal the way it was written. It was the original panel, expert panel, was a skewed panel that were anti-opioid for sure. There's been a lot of writing about this. You could Google and find it. I've written a lot about it. A lot of my colleagues have written about it. So the panel that was put together initially was a problem. Some of the guidelines are totally inappropriate. Some of them are fine. Some of them are common sense. One guideline talks about if you don't respond to opioids, then you should abandon opioid therapy. Well, that's ridiculous. If you don't respond to opioids, maybe you need to be on a different opioid. Maybe response is not what you're looking for. Improve says if you don't improve. Maybe improvement's not what you're looking for. Maybe you're looking at a diminished deterioration. So in patients who have Parkinson's disease, we're not going to see an improvement, but if we can prevent some deterioration, that's a good thing. So some of the guidelines make absolutely no sense. I think that some of them are common sense, and that's fine. But they were not meant to be policy or regulation. And when these guidelines were written by the CDC, we knew that they were going to become guidelines that people followed. The same group that was involved in the original panel for the CDC guidelines filed a petition in 2012 and asked the FDA to change the indication for opioids from moderate to severe to only severe, that nobody could have more than 100 milligrams of morphine equivalent for greater than 3 months, and that if you didn't have cancer pain, you shouldn't be on opioids for greater than 3 months. That petition went to the FDA, and the FDA shot it down. So the very same people went to the CDC and tried to get in the back door with the CDC. And it was done in a very clandestine way. And it's been exposed, but nevertheless, it happened. And so here we are today. Here we are today. Well, Dr. Fudin, I know you have to, we've gone over our hour, and I know we could talk to you for probably a few more hours. Was there anything else that you wanted to mention before we get going this evening?
No, I want to thank you for the opportunity to be here tonight. Some of the questions I think that were asked, I think that some of the folks that they asked those questions should probably go on the internet and look in some of the chat rooms, as they probably already do anyway. They can read some stuff that I've written on the CDC guidelines. I've got another article coming out probably in a month or so. They are welcome to go and check out UrinTel, which is the app that I told you that I wrote. So that if somebody's accusing them of doing something wrong with their urine screens, they can check it out themselves.
Solely for doctors or patients and doctors?
I'm sorry, can you say that again?
UrinTel, your app, is that marketed solely for doctors, or can patients use it too?
Anybody can use it. It's available on for cell phone. You would have to register on the site first, and then you can upload the app to your phone. It's like $15. You put the drugs in on a drop-down menu. You put in the daily dose, and then it's pretty self-explanatory. It's for anybody, right? Because I feel like the clinicians and the patients should have an equal playing field. It is what it is, you know. If it's unexpected, it will tell you it's unexpected. If it's a problem, it'll tell you it's a problem. And if it's undeterminable, without doing definitive testing, it will tell you that. It is what it is. You know, so I think it's fair to everybody.
Okay. All right. Well, thank you again, Dr. Fudin, for coming on. We had a lot of great questions, and I hope maybe you come on again. That would be great to have you.
All right. Fantastic. Have a nice evening.
You too. Well, thank you, Carnation, so much for joining us this evening. And I appreciate all of your wonderful questions, and especially on YouTube as well. I wanted to let you all know for next week, our guest on Tuesday is going to be Dr. Ronald Myers. He's going to be discussing the rally that he'll be having in April, the end of April, for African-American doctors in general, and going over about the opioid issue. And also Anita Thompson on Wednesday. She is the head of a I don't want to say nonprofit. I'll find out for sure. But she is the head of a major advocacy group for sickle cell patients. So I hope you have a great night, and thanks again for joining in.
Listening to Conspiracies Against Wellness with your host, Janelle Elgaway. The opinions expressed on this program are those of the host and callers, and not necessarily those of EXG LLC, its employees, or sponsors. By EXG LLC. All rights reserved.